Hello, and welcome back to our course One World, One Health, and One Medicine. I hope that 2017 have been treating you very kind thus far as we continue our seminar series. As you may recall, in January, we began this course by reflecting on 40 years of One Health, One Medicine at St. George's University as we began our anniversary celebrations, in fact, with our founder and chancellor, Dr. Charles Modica. Throughout this year, we will be exploring the full spectrum of the definition of health, which includes physical, mental, and social well-being. We will be examining health from different geographical perspectives around the world. And in doing so, we will be engaging several of our expertise, several of our academic schools and programs at St. George's University. With that in mind, we'd like to welcome Dr. Wendy Crawford-Daniel to share with us the seminar today. And in the theme of understanding the physical, mental, and social well-being, we are focusing on the social aspects of health for the month of February. Dr. Wendy Crawford-Daniel is a professor of sociology in our School of Arts and Sciences at St. George's University, and she's very much a renowned sociologist, not only in the Caribbean, but one who has written a lot on the topic, and we feel very confident that you will only be enlightened by her presentation today. Welcome to the course, and I will leave you now in the capable hands of Dr. Crawford-Daniel, and we'll be back as we begin our discussion after the seminar. Dr. Crawford-Daniel, it's over to you.
Thank you very much. Thank you. The topic today, health, a result of society and culture. Today's presentation will focus on how our bodies are affected by social influences. The underlying philosophy or theme that will run through this presentation is based on the notion that health and illness are complex and highly political phenomena. The goal of today's presentation is for healthcare providers to achieve a greater appreciation of the social and cultural aspects of health so that you can work effectively with individuals and families from socially and culturally diverse communities. With a greater appreciation of the social and cultural aspects of health, you will be able to provide culturally sensitive and appropriate health care, health education, and counseling, and in many ways or roles within the healthcare system that we have. The objectives of this presentation are: 1, to interrogate the inseparable concept society and culture. 2, to show the interrelationship and the interdependency between society, culture, and health. And 3, to demonstrate, using a sociological approach, how health and illness are equally determined by societal and cultural influences. Now, before discussing the intersection of these three concepts, I would like to provide a brief review of the definitions of the concept health, society, and culture. For the purpose of this presentation, I will adopt the World Health Organization's definition of health. World Health Organization defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. To further elaborate, World Health Organization has set as their primary healthcare goal better health for all. They have further elaborated 5 guiding principles that will help in achieving the goal, and these are: 1, reducing exclusion and social disparity in health, a principle heavily inherent on social factors. Two, organizing health services around people's needs and expectation. Again, a principle at the core of cultural factors. Three, integrating health into all sectors, taking a multi-dimensional approach, and that encompasses, of course, sociological methods. Four, pursuing collaborative models for policy dialogue that addresses, of course, the social and political structures of society, and increasing stakeholders' participation, which is the inclusive nature of social factors. And these principles are outlined in World Health Report 2008. The important issue to tag here is the holistic nature of this definition and the inclusive nature of the guiding principles that give equal primacy to social factors of health, which include the cultural, the spiritual, the environmental, the political, the economic, participatory management, and ecological components of health, as is given to the biological. The World Health Organization is stressing here that health is a fundamental right that can only be realized through the action of many other sectors, including the socio-cultural aspects of health. Health, therefore, is conceived of not as a single-dimension phenomena, but a multi-dimensional one as conveyed in the definition. These definitions and theoretical underpinnings will guide today's discussion of health, a result of society and culture. For as embedded in the World Health Organization definition of health, it is necessary to learn about the broader socio-economic, political, religious, philosophical, ecological, and cultural context in which one's health is impacted. Another critical concept in today's presentation is society. The concept society is one of the most important of all sociological concepts or notions. A society, according to Abercrombie, Hill, and Turner, 1994, is a system of structured social relationships connecting people together according to a shared culture. The important aspect to flag about society here is not necessarily the notion of a physical structure, but the system of structured social relationships connecting people together according to a shared culture. Sociologically, society is conceptualized as a system consisting of many subsystems, like education, for example, the family, the legal system, the economic system, the political subsystem, and of course, the health as a subsystem of society. Each of these subsystems, however, are interrelated and interdependent on each other for the continuity and survival of society. Now, like society, each of these subsystems can be conceptualized as a system in their own right. The health system, for example, comprises subsystems of care providers and care seekers, care administrators, a subsystem of policies, legal and ethical frameworks, and like society, these subsystems are characterized by structured social relations connecting people together according to a shared culture of that health system. The other major concept in today's topic is culture. Now, culture is a broad, complex concept. It encapsulates the shared ideas, the meanings, the socially learned values and patterns of behavior, and of course, the lived experiences characteristic of a given group. Like society, the concept of culture is widely used in sociology and the social sciences. So culture is the vast structure of behaviors, ideas, attitudes, values, habits, customs, language, rituals, ceremonies, and practices unique to a particular group of people. Collectively, culture shapes one's development and creates a lens through which one views, interprets, and experiences the world and the people in it. So culture is one of the most distinctive properties of human social association. The culture in which we are raised greatly influences our thought processes, our knowledge base, our attitudes, our beliefs, our values, behaviors, and of course, lived experiences. And this includes beliefs, values, and behaviors as they relate to our health. It is therefore important for you, the healthcare provider, to gain an awareness of your own cultural determinants as well as of those cultural groups to whom you serve or you provide care. It is imperative for me to give you a quick definition of a cultural group because it's important for today's discussion. A cultural group is defined as people with common origins, common customs, and styles of living. The group has a sense of identity and a shared language. Their shared history and experiences shape the group's values, their goals, their expectations, their beliefs, their perceptions, and behaviors from birth until death. Too often in our anxiety to provide care, we ignore or bypass the social and cultural considerations and encounter serious problems in diagnosing, treating, getting clients to comply with a medical regimen, or even understanding our clients' help-seeking behavior. Many healthcare providers have a tendency to view his or her own cultural group as the center of everything, the benchmark or the standard upon which all others' values, behaviors, and ways of life should be judged. This lack of understanding of and lack of respect for differences has led to discriminatory practices and ineffective interventions. In the social world, we call that practice and thinking ethnocentrism. Taking these three concepts together, health, society, and culture, one can see clearly that health is provided within a political system that emphasizes a particular policy orientation with distinct social relationships and informed by health attitudes, health belief systems, values, and behaviors that directly affect one's health and lifestyle. So in order to provide culturally sensitive care, healthcare providers should approach their practice by first understanding that any behavior must be judged first in relation to the context of the culture in which it occurs. This we term cultural relativity. That is a conscious effort to understand a behavior within the cultural context in which it occurs. It is important that we are sensitive to our clients' interpretation of their experiences from their own background and cultural belief systems before we can effectively intervene. Ensuring that health is a result of the structure of society and vastly influenced by the cultural parameters of that society, I will examine three sociological perspectives on society that form the underlying basis or the philosophical thinking behind the type of health system we pursue. So, different sociological perspectives. Let's just get to that point of the theoretical perspectives. Different sociological perspectives look at society differently. Theories within the functionalist tradition see society in terms of functional relations between social institutions and social groups. Relating this to health, one can focus attention on the nature of the relationship and interaction that take place between health professionals and healthcare seekers. The theory posits that every person occupies a number of different statuses at any given time, and every status carries with it socially prescribed roles, physician role, patient role, which I'm sure we're familiar with, which is a set of expected behavior, attitudes, obligations, and privileges. For example, the healthcare provider and seeker, such as physicians, maybe nurses and clients, are characterized by organized patterns of social behavior as an element of social structure. A theory that argues that society has certain needs that must be met for survival, and institutions have to be set up and seen as meeting those needs. This perspective holds further that once healthcare providers and healthcare seekers know their role and responsibilities and respect their assigned social location in society, their healthcare activities and activities in general will ensure the integration and stability of the healthcare system and society generally. This perspective considers inequality within the healthcare system as functional or having an important interdependent stabilizing function. This theory asserts that in all societies there are positions that have more functional importance than others and need special skills if they are to be performed efficiently, hence the basis for the functional inequality. It is important to note that this thinking of functional inequality still informs many health policies in some countries. A policy that view the inequalities in society and in the health system as functional and necessary for the maintenance and stability of the system. The other theoretical perspective I would want to look at that influences the type of health care that we provide or that is available is one that looks at society from a point of view of social stratification. The concept of social stratification is based on another sociological perspective that posits that groups in society experience patterns of health and illness differently, and this is due to their social location or their social status. This perspective shows the powerful ways in which societal structures and social processes shape lives and health of individuals, communities, and populations. It peels away the seemingly orderly and stable cover of society to expose the basis for the underlying disparities that exist between social classes in society. The theory emphasizes that it is the ownership structure of society that is responsible for all the social inequalities in society, including the disparity in health. And unless the ownership structure does not change, the level of inequality and disparity that we witness in society will not change. Social structure refers to the enduring, seemingly orderly patterned relationship between various elements in society. These structures can be, and when we think of structures, not necessarily physical structures, these structures can be relationships between various elements in society. They can be social institutions. They can be assigned roles. They can be the responsibilities. They can be organized patterns of social behavior. They can be functional relations between social institutions. It could be the nature of the power structure, etc. So these patterned relationships may be directly observable, or they can be abstract formulation. So irrespective of the form they take, social structure is used from a sociological perspective to explain social situation. It provides a causal explanation for social phenomena. So the notion that health is a result of society and culture is hypothesizing that the social structure of a society determines the prevailing health status of the citizens in that society. So those within a structured perspective see the patterns in society as externally imposed on people and having a life of their own, independent of individual action. So for that perspective, much emphasis is placed on analyzing the nature of the social structures or the social stratification in society in terms of power distribution, a perspective that stresses that the social patterns that exist is because society is divided into classes or elite groups that dominate subordinate ones, and that dominance is manifested in the structure and type of relationships in all subsystems in society, including the structure of the health system. This theory posits that groups in society experience patterns of health and illness differently, and this is due primarily to the location in the social structure or the socio-economic status, as we refer to it sociologically, which we refer to in the social science as social stratification based on class. So social stratification is a system of ranking people hierarchically along some dimension of inequality, whether the inequality is based on income, wealth, power, education, prestige, or socioeconomic status. Other forms of social stratification include that I know we are very familiar with: age, ethnicity, gender, sexuality, religion, race, and disability, etc. These are all conceptual ways in which people differ. According to some theorists ascribing to the worldview, those who own and control the wealth, the resources, and assets in a society will determine the type of healthcare system and the health policies and practices that will prevail in that society. Several studies have identified one's socioeconomic position as a determinant of health. Some studies have shown how one's income level is closely associated to healthcare accessibility and ultimately one's health and quality of life. Lynch and Kaplan 2000, Borkman and Glass in 2000, Galabades in 2007. Other studies have shown how one's education level is closely associated to better illness prevention, behaviors showing a positive relationship between education and health. According to a study by Lynn and Kaplan in 2000, higher levels of education are positive predictors of greater ability to purchase health-enhancing goods and services. The other perspective I'm going to focus on to give an idea of how the society is structured differently that provide different types of healthcare for its people is the interactionist perspective. The interactionist perspective critiques the social structural approach in explaining the disparities in health and wellness, claiming that approach does not give primacy or enough emphasis on the meaning individuals give to their everyday lives, of which their health behavior is paramount. Sociological analysis of health that has adopted the biopsychosocial approach has shifted the discourse, and rightly so, from individuals with medical problems to individuals, families, and communities and practices that occur in the context of the wider social world. So in addition to taking care of the medical issue, such an analysis will look at the context within which the individual is defined as ill, becomes ill, seek treatment or not, comply or refuse to comply with treatment regimens, the health, the financial or economic policies under which care is provided, the environmental and ecological issues impacting health, the cultural competence of the healthcare workforce, the technological environment, and trends in complementary and alternative medicine, and the state of health and nature of the social stratification in the society. This perspective urges the healthcare workforce to understand clients from the point of view of their lived experiences or culture, however different that is from that of the health provider's culture. Both healthcare provider and healthcare seekers have widely held beliefs about what is worthwhile, desirable, and important for well-being. That theory emphasizes the importance of culturally competent approach to health. Through interaction with health providers, healthcare seekers provide definition of their situation or convey to providers what factors are important for their well-being, what they consider a state of wellness and a state of ill-health consist of. It is important for the healthcare provider to understand from the client's perspective if illness is explained by the germ theory, by biopsychosocial factors, or supernatural forces, or the imbalance of hot and cold, the yin-yang concept, or a disequilibrium between nature and man, or is it explained simply by fate? Applying this social theory to health, care providers will seek to become culturally competent in providing the appropriate care. Using a client-centered approach, care providers are likely to understand the deeper cultural issues like what values, beliefs, and behaviors clients possess concerning the cause, the prevention, the diagnosis, and the treatment of illness, what health conditions clients consider normal or not, what beliefs people have concerning the organs and systems of the body and how they function, what are people's attitude towards vaccination and immunization, various screening tests, and other preventative health measures. They'll be interested in the meaning of mental health. Are there any taboos or other beliefs connected with mental health in that culture? What are the attitudes towards psychological and emotional health in the culture? What is a prominent medical belief system in that culture? What are clients' attitudes and beliefs towards disability of persons of various ages, sexes, racial and ethnic groups, religions? What are clients' cultural beliefs about the body, about discussion about the body, and about self-examination? Are there any taboos or restrictions in the culture on who can see a woman or a man's body? What are the attitude towards examination of the body by medical personnel? What makes clients uncomfortable or embarrassed in the culture? Then there are cultural beliefs about death and dying and bereavement. How does belief about death and dying affect the health program routines? What are people's beliefs and attitudes about personal hygiene, for example, pregnancy, childbirth, childcare? What are the attitude towards sexual behavior in the culture? How easy will various people discuss sexual topics? What are the social and cultural beliefs and practices concerning menstruation, rites of passage, menopause, and other various life stages? Are there any special rites, rituals, or taboos that must be observed? What are social and cultural beliefs and practices surrounding sexual intercourse and conception? What are the attitudes about homosexuality, bisexuality, and other forms of sexuality? Now, embracing the social and cultural aspects of health will require of you, the caregiver, to understand the psychological and socio-cultural makeup of the group you are serving. What is the attitude towards the environment? What is the predominant worldview subscribed in the culture? Do they have a worldview that they can have mastery over nature, or one that emphasizes harmony with nature? Do they place more emphasis on materialism versus spiritualism? How much overlap is there between the system of religion and medicine? These are factors that will be important if you are taking a culturally competent approach to providing medical care. Are there special beliefs concerning what or who cause various illnesses, and whether and how these illnesses can be prevented, diagnosed, or treated? How do religious groups affect the secular practice of medicine and the health belief system of their followers? How do they affect the utilization of healthcare facilities? How do they affect the organization, the practices, the policies of medical care? It is also very critical to understand the behavioral factors. How do calls for medical help occur in the culture? What signs do people give when they feel they need treatment? How do clients use and convey nonverbal gestures and communication in the culture? So equally critical for healthcare providers is understanding that your own attitude, your belief and practices concerning health, illness, and medical care can bias your understanding of your clients. You will be better equipped to provide culturally sensitive and appropriate care with a good understanding of your health belief system and your clients, and an awareness of how your own cultural values can influence the quality and appropriateness of the care you provide. Providing culturally competent care should become a professional ethic within the healthcare profession and should form an integral part of the professional training at all levels in the industry. So in this presentation, we looked at different perspectives on society and see how much each perspective differ and how each perspective influence the type of healthcare philosophy and healthcare system that prevail in the culture. One theory sees inequality in society and in the healthcare system as necessary, as functional, or a motivating factor for society's continuity and the maintenance of the healthcare system. This view of society favors basic reforms to the branches of society, but not to the core or general social structure of society. We looked at another perspective that sees society as structured in such a way that constrains our life chances and sees society as divided into classes, with the most powerful of these classes wielding power as the basis for holding society together. The dominant class in society has the power to shape society's institutions, including the health system, to serve their own interests and perpetuate their own control. This theory posits that for disparities in health to change, the social structure or the ownership structure and social relationships of society need to radically change. We also looked at a perspective that focused neither on the functional institutions nor on the exercise of power. Rather, it looked at the value systems, the beliefs and symbols people in society share, and the meaning people place on what is important in their lives for their health and well-being, or what was referred to in this presentation as their culture. This theory posits that ending disparity and discriminatory practices in health is only possible when the healthcare workforce is equipped with the practices, cultural competencies in the provision of care. In other words, when the healthcare workforce is equipped with and practices cultural competencies in the provision of care. So there are many other ways of viewing the world and the system therein, through which each of the perspective examined today brings though each of the perspective we examine today brings something different to our understanding and analysis of health, there is no general consensus on philosophy or practice, thus lending further explanation for my opening statement that health and illness are problematic and highly political phenomena, which, of course, we can open discussion about at this stage of presentation. Thank you very much.
Thank you so much.
Thank you.
I believe we're going to take some questions now. Is that correct, Dr. Bedesi?
Sure, we'll definitely look forward to engaging our audience on questions as well. And maybe if I can just share a couple of comments, maybe a question of my own. As I was listening to your presentation, I recognized the structure and the sort of defined roles that society and culture have to play in our lives. But having said that, though, if we look at the changes in the world in which we live in today, where societies are now overlapping with each other, where the boundaries that once confined us culturally are now mixing. So as the socio-cultural dynamics of who we are as a people continue to evolve over time, how is that then challenging the sociologists in terms of understanding people when they're no longer particularly defined to any one location or any particular behavior? They're now very much integrated with each other.
I can approach that from two angles. Sociological, we speak of acculturation, meaning that increasingly persons may adopt behaviors and values of the majority culture, and that plays a lot. We see that in immigrant population who might migrate into another culture and have to live there. But there is another argument which says that people do not let go so easily of their cultural belief systems and their values. So even though they may migrate from a minority culture into a majority culture, they tend to bring with them the value system that is inherent in the culture from which they're coming. And so there is that expectation that, so for example, that's why we find a sort of dual approach to care. And I've seen it practiced a lot in, let's say in Jamaica, for example, there is a very strong pattern of integration of informal medicine with formal medicine. So clients or patients know if, for example, they cannot be helped or from the formal medicine, there is a referral system where you are referred to informal medicine as the alternative approach. So culture is something that is not easily eradicated, even if you have moved from a minority culture into a majority culture. You still have to take into consideration that these are deep values that people were socialized from birth. And so you do not let go of it so easily. And it makes it even more important why we need to adopt a sort of multicultural type of understanding of the practice of medicine, because here now we have a mix of all different cultures and we need to provide care equally for others, thus ending the disparity or inequality that we often see.
Interesting enough, I always tell our medical students here at St. George's University that you can study medicine anywhere in the world. In fact, you have medical schools around the world. The curriculum and the knowledge base is not necessarily that much different. But what we believe is unique and definitely reflects with our success of our graduates is the diversity of our student body allows for that competency, that cultural competency, that social competency, which they can then translate into their medical practice as well. So we see a lot of value association with not only understanding the socio-cultural complexities of our patients, but for the healthcare providers to also assume that understanding of the complexities to then reflect that onto the care that they provide for the patients as well. Sure. Okay. Any questions, any discussion points from our listening and viewing audience? Well, if you have no questions at this point in time, no, but it's a very complicated topic because I'm also thinking from my own experience in terms of population health. We explore the physical aspects of health. I'll give you an example. We look at different occupational groups. We look at nutmeg processing workers. One of the occupational related risk factors of nutmeg workers is in the processing of nutmegs. So you're drying nutmegs in a tropical environment, warm, moist tropical environment. prone towards development of Aspergillus fumigatus, or mold.
Mm-hmm.
And when these workers are processing nutmegs, this mold aerosolizes, and as part of airborne transmission, you can have some type of upper respiratory symptoms associated with it. And we do have nutmeg workers that are displaying upper respiratory distress. So that's the physical part of it. But then, when we also examined some of the life experiences of our nutmeg workers, we began to recognize that there is a phenomenon called adverse childhood events, which is called ACEs. And somehow those that are more prone to the upper respiratory distress are the ones that would have identified with adverse childhood events. So here we have a phenomenon where previous experiences would have informed their body's own reaction and response to the environmental exposure to the mold as well. So it's very much an intermix between the physical aspect, the environmental aspect, and a lot of social consequences to that as well. And any questions coming in online?
We have quite a few who've typed in some questions, Dr. Bedesi, so I can either read those questions or we could ask the students if they'd like to ask them via audio, whichever you prefer.
Well, maybe we can start with one, and in case we can invite students who have also typed in the questions, feel free to open up themselves to ask directly also.
Yep.
Great. So Desiree has her hand up, so I'm going to enable her audio first.
Hi, Desiree.
Hi, are you hearing me?
Hi, Desiree, yes.
Hi, I got everything that you're saying, and I agree with a lot of what you're saying regarding culture and medicine coming together, because there needs to be integration. But what I wanted to know was, like, regarding integrating healthcare and culture, how can healthcare providers become more integrated with culture? What can be done by medical boards, like, around the world to make sure that their healthcare providers are aware of what is happening in society so that they can be less stereotype less and become more aware so that they would be better at treating their patients?
Good question. I think I touched a little of that when I said maybe the profession and at every aspect of the industry should consider cultural training, cultural competency training as part of the formal training for medical care workers at every level, not only at the physician level, but all the entire levels, as once you are engaged in any type of provision of care or interaction with other people, that as in a formal way, incorporate as much of the social, cultural aspects in the training. So I know some schools, I think, has already begun or is doing that type of mix and integrate interdisciplinary approach to understand where the problem lies. So putting it formally into the curriculum or into some form of training is a good way to start. I know we do it here at St. George's University, a number of courses we call social science and medicine to show the social side of medicine or the human side of medicine. And that involves a lot of that type of training for our pre-medical students and pre-vet students, I think. Yeah.
Interestingly, as a physician, you do not determine which patient walks into your office.
Exactly.
Who presents an emergency room.
Exactly.
It could be essentially anyone from anywhere. And you have to be able to respond to the medical as well as socio-cultural needs for that particular individual as well. Sure. Yeah.
Thank you. Deja.
So we can have some more questions?
Yeah, I think Leopoldine had a few actually. Leopoldine, would you like me to unmute your audio? If so, just raise your hand, click the raise hand button, or you can just type your answer in the chat box. We'll wait a second, and then I think I'll just read your questions for you if we don't hear from you. Okay. So Leopoldine's question, in your introduction, you raised briefly the political issues of health system. Do you think that they should be considered to explain and improve some of their health policies, social conflicts, and other behavioral habits?
I think that's the core of what I am saying. I remember I started off saying that health is a very political, because basically it is centered around policy. And policy, all policy is based on some sort of theoretical or philosophical understanding of what is it that you would want to do. So it is very difficult to get out of a political arena when you're speaking about any issue of policy surrounding health. And so it seems only natural. It's very difficult to remove the political from any practice of medicine, because whatever the theory or the philosophy behind the structure of the system and the details of the policy that might be embarked upon, if you take apart these things, you are going to see underlying all of that a thinking, a way of thinking about that particular issue. And so all of these issues are so very political, because when you look at it at the surface, you may not see the level of politics or the structural issues that's involved, or the theoretical issues and philosophical issues that's involved in establishing a particular approach, a policy, a program. But it is taking it apart now to see, according to some of the theories, like the conflict theorists will ask, for example, in whose interest is this policy or this particular program? What is the rationale for providing this program or this policy, and whose interest is it based on? The functionalists will also take an approach when it comes to the political aspect of it, that may say, well, to be a physician is very costly, it's time consuming. People make you make an effort to, you have made a decision to invest a certain number of time in a particular area. You have made a lot of sacrifice, and therefore it's only natural that your returns should be greater than someone who did not invest that time in terms of training and all of that. And so there is an explanation, for example, in the disparity that will exist between a physician, who what we know is at the top of that professional, the apex of the professional scale. So you think about these issues not just on the surface of what you see, but you try to understand and get beyond just what appears to be, and understand the deeper social issues that can explain different phenomena. So even from the cultural level, much of the things that we do and think of culturally, we come into an environment with our own belief system, we come into an environment with our own ways of seeing the world, our own worldview, and immediately make judgment without understanding the context or the perspective in which our client or someone else is looking at the same phenomena but seeing something completely different from what we are seeing. So it is a comprehensive
matter of perspective as well.
Yeah.
Different people have different perspectives.
Different perspective, that's right.
How they look at a particular issue. Exactly. Sure. Okay, thank you.
We have a hand up from, and I apologize for the mispronunciation, but Tremaine. Just one second. Tremaine, you should be able to speak now.
Hi, good afternoon.
Good afternoon.
Okay, I just have a comment. I think that management has to start making records digital. I think that if the Caribbean could all have more records that are digital, since we all, as doctors, we write down things, but they never get to be shared because they're on paper. I think that would help the Caribbean a lot to have a Caribbean database.
So we're looking at the issue of electronic medical records and digitizing our health services as well. And that in fact is a conversation that the Caribbean region is having broadly, and separate islands and even within the countries, different institutions are also transitioning the health services towards that electronic model. But I think that also stems back, if I may, to the whole issue of social and cultural influences, because as a region, we may have had some type of value association or disassociation to the digitizing and the electronic conversion to some of our data. Some people may have their own attitudes and perceptions towards the fact that their data, if it becomes digitized, it might become very accessible to people, for example. What are some of the consequences of that? But we agree that as a region, and generally in terms of all health services, there is a need to make decisions based on evidence. That is probably the fundamental way in which we can attend to population's health. Evidence is part of data, but I also appreciate that evidence comes from people's own views and values and belief systems at the same time. You know, so that whole aspect of digitizing, electronically converting the health services can potentially make it more efficient and make it more relevant to the needs of the society. But of course, we have to be able to want to do so as well, and that is where the culture of our researchers, the traditions that we had previously of recording things in books or not recording, as the case may be, that also has to change as well at the same time.
And Tremaine, hi, I remember you. And that also explains that multidimensional approach and the need for integration, because much of the methodological approach used in sociology, whether it is doing research using a quantitative method or ethnomethodological method, meaning getting the life stories of persons, all of this very rich and powerful data that can be compiled and kept so that those who, for example, a physician will say, you're asking us to do all of these things. Where do we get the time to do all of these things? And it will be unfair to ask a physician, for example, to have to take care of a medical condition and to go and research and get all of this information for themselves. So packaging that information could be very useful for physicians, use as a tool so that they have a better appreciation. If someone from the Caribbean walks into the office for some type of attention, they know, they have an idea of the communication style. They have an idea of how we relate our symptoms. They have an idea of why maybe we may put more emphasis on the spiritual aspect of things and say, well, I'm not sure if this treatment is going to work because this is how it is, and this is how it ought to be. That was designed somewhere else. I have no control over that, right? So if we can provide that kind of information and data, compile that data, it will be very useful for healthcare providers rather than they having to go and get all of this information themselves. That is where the integration and the multidisciplinary approach comes in very useful, because as sociologists, as anthropologists, as criminologists, and all the different areas of the social science, as economists and the areas of the social sciences, we can put these that sort of data together so it becomes a more easily available in a very easy and user-friendly manner for those who would need it to inform their practice. So thanks, Tremaine, that was good.
Any other questions, guys? One question that I have, as I understand health, if we were to think of the evolution of the determinants of health, we have looked at the germ theory, thinking about health as being dependent on microorganisms, and then we developed the microscope. We built antibiotics, antimicrobial drugs, vaccines for it, and then as post-World War II, as societies changed, we began to live longer. Our behaviors changed in terms of our diet or occupations changed. We began to observe lifestyle-based diseases, chronic conditions. And now we're seeing the environment also being a significant determinant of our health in terms of the exposures to the environment. So we're seeing a change in the way we understand health. Today now, we really begin to appreciate the significance of the social aspect of health, because at the end of the day, an individual is a social creature, and their functions and their pathology from a disease perspective is enshrined in their social aspects as well. I'm always of the belief that behavior is one of the main determinants of health. But what drives behavior is knowledge, attitudes, and perceptions. Because how I perceive something is going to dictate how I view it or how I respond to it.
Exactly.
But the actual perceptions that I have is based on my knowledge, based as a child, or my exposures to my environment, my family, my friends. So society dictates that. So invariably, our behavior is a function of society. So if we are to really inform healthy behaviors, which is a need as we try to tackle this growing burden of chronic diseases, we have to really focus on the social influences of behavior as well.
Yes, that's very true. In the in social science or in sociology, we have a term for that. We speak of socialization, and that is how we begin to learn from childhood and the agents of socialization. Be in the family, you learn through your religion, through your home, different ways of behaving, different values at school, through your peer groups, your friends, from the media and the whole range of media. So we learn, and one of the things that our approach in sociology is that the world, nothing remains the same. Everything is relative. So if we today look back 100 years and we say, how is it possible that people couldn't even imagine that this is a particular way to live? You know, but we have to understand that as everything else, education, knowledge, technology, everything is improving, increasing at a very slow incremental rate. And so even when we look at all of these situations now, we can say, go back to the core areas of socialization, go focus again back to where people begin to learn. Because sometimes you have to think back, we need to go back maybe to the family, socialization. We need to go back to all of in the school system, which will have implications for the type of curriculum that we teach, the extent to which we can reform in keeping with the development and the development of our knowledge base, so that if we do not remain with a dead and constant curriculum throughout our life, but as things evolve. And that's the beauty of research, because when we do research, we are able to refute theories that no longer hold. We're able to develop new theories about particular phenomena. We're able to expand on theories about particular phenomena. And so that type of constant evolution of society and knowledge and technology, and so impacts in some way. But if we remain not going along with, in terms of professional training and all of that, if we do not keep up and go along with that process, then we'll have some problems in how we deal with many of these issues that you raised. So
I'm also cognizant of the fact from a One Health, One Medicine perspective as well, thinking about the interactions with humans, animals, and the environment. When we look at the issue of pets and human interactions with pets, that has changed over time. And society has actually driven that change, where we are seeing in developed countries families and homes that have more pets than children sometimes. And what is the role of the pet animal in terms of the human structure and function in society? And then how that drives the disease process in terms of any particular spillover effect from the species onto humans. So we're seeing an increased intimacy, an increased diversity, because we're increasing our range of choices of pets.
Where pets have become a family, pets have become a member of the family now in some societies, and it's treated as a member of the family, just as any child or maybe treated as a member of the family. And increasingly we see, for example, in working with the aged population in social gerontology, we're seeing increasingly when the elderly speak sometimes of their quality of life and the significance and the meaning that pet bring to their lives. It's amazing to listen to the stories about, the extent to which that interaction with their pet is bringing some quality to their life and meaning to their life. So it's just a whole range of development and phenomena that, you know, need to be considered when we think of the social aspects of health, because interaction is what is the focus of the social aspect, you know, the relationship that we share. So whether it is physician-nurses relationship, physician-patient relationship, or just relationship among colleagues, these types of relationship is the focus of much of what we do in sociology. So when we speak of the social structures, we're basically speaking about the nature of the relationship that exists between these entities, right, that comprise the health system, and not necessarily a physical structure, you know, that structure of the, because in the social world, we think that even the communication style is structured, the nature of the communication is structured, the interaction is very structured. Still a very hierarchical structure, but it is structured. And so we look for these sort of variables that you do not necessarily see with the naked eye, but lie under the surface of all of these. And that's the depth of which the analysis that we go in when we do the social world. We do not take any behavior as is, but we try to get to the bottom of understanding a particular behavior. So when, for example, a Grenadian elderly, a 70-year-old Grenadian elderly say, I am not going to do a very much required surgery that is a life-saving surgery. I will not do it. And we will want to find out, why won't you do it? Because naturally, in our own thinking, that why not? The technology is there, the facility is there, and they will say, I have lived my share. I was given 70 years, 10, a very strong religious type of approach to. So I am 70 now. I've lived my time. Any time beyond this is borrowed time or somebody else's time. So I will just let it be and will not take surgery. You find these types of comments that, and you know, you try to understand why this person do not want to adhere to a medical regimen or do surgery or something. So we go deeper to understand, not just I'm not going to do it, and that's it. We go deeper to understand the basis or the rationale for some of the type of decisions people make in the medical field, you know.
It's all very interesting, you know, but how can we package this though in the physicians today that have X number of minutes
Tell me about it.
to conduct their history, taking the physical examination and move from patient to patient? Because what you are referring to requires for an in-depth examination, not only of the physical aspect, but the life history and experiences of these particular persons. And that seems to be necessary in terms of the determinants of health. But how feasible is it in terms of the processing of multiple patients in a given time period?
Right, and that is why I'm saying that sort of integration of the different care providers in whatever field. We need that at a very early stage. You see, you do not need sometimes the detailed information, but at least being exposed to that thinking which says, my way is not the one and only way. So you're now open, right? You're now open to listen and understand. Sometimes it just means an additional 2 minutes to just understand from the perspective of the patient. So it's not that you have to study a litany of behaviors for everyone, but it is a worldview, a way of thinking about your patient or a way of thinking about your clients that, okay, they're coming to me, they have a story. So before I quickly jump to diagnose and prescribe a treatment, let me hear what is that is deeper than my eyes can see, right? So it's more, the training should be more an openness, a willingness to be open and to understand other cultures, understand there are different ways of seeing the world. People come to you with different perspectives, different ideas, different value system, and so you, as a physician, will not have time to learn and study all of this. But if you have that disposition, if you are trained with that disposition to be open to other person's ways of life, values, culture, then you can learn there and then. You don't have to learn it before. You understand? So it's really internalizing that type of openness as an approach and a willingness to listen to others, see what's going on, that kind of thing.
And I really guess it makes absolutely no sense treating a patient, let's say with lower backache, with long-standing anti-inflammatory drugs, if they are only going to return to the very same environment that is causing the problem to begin with, whether it's their work practice in the workplace, in terms of the chairs they have to use, you know, so, or whether it's the lifting of heavy objects based on the functions they perform at home. So we also have to recognize that in terms of treatment of people is not necessarily just the symptom, but also the whole context that surrounds that particular patient as well.
Or even the quality of the mattress they're sleeping on.
Exactly.
Or the bed
and the socioeconomic consequences which decides that also. Yeah. Okay, sure.
I know Karina has a question. She wants to know, is there a reason to be optimistic that Caribbean societies are likely to be more proactive about mental health policy?
Repeat that question.
Caribbean societies.
I think it's. I'm going to even rephrase it a little bit. And Karina, if this is not correct, just let me know. But I guess is there any evidence that we should be optimistic that Caribbean societies are likely to be more proactive about mental health policy in the future?
Well, okay. Personally, I am always optimistic about everything, and as a sociologist, we live on optimism because we understand nothing remains the same. And if you understand Caribbean society, mental health is still a major taboo. We do not pay enough attention to mental health, and it is still an illness that is seen where families are ashamed of the illness and try to hide it as much as possible. But we are seeing little improvement in that, and increasingly, and that improvement we are seeing is because more and more the persons who are into mental health, we're seeing more and more psychiatrists, we are seeing more and more psychologists in our societies that in the past, psychological problems were dealt with in a closed circuit, in a family situation. People were not open to go into therapy, they were not open to go into counselors, but increasingly we are seeing that type of development, which means that in the future, it can only get better. It is still at a very, very low level of development, but I am optimistic, and I'm sure that with the work of the in St. George's University, for example, or the University of the West Indies, in the Caribbean and the other universities, that more and more we are understanding mental illness for what it is, and not because there are some strong cultural beliefs about mental illness, you know, that have a lot to do with that can happen to you. Some folk beliefs about mental illness, that someone can do something bad to you that can result in mental illness. Basically,
it could just be that people think that you're crazy,
or people think that you're crazy, and there isn't right. It's never a concept of disease. It could be some sort of spiritual you're inflicted spiritually by this thing, or that somebody who evildoer can do it to you. So there are a lot of this kind of thinking about mental. So if it is done by an evildoer, there is no way the physician can help. And so increasingly, as we increase our education about mental health, people are letting go of some of these thinking about mental health and approaching it more as what it really is, and accessing more care. So I see that as it's a little incremental improvement, but over time we will see a lot of work done in that area. So
I know many countries in the region also governments are putting in place mental health legislation.
Right.
Increasingly across
facilities
across the region.
Sure.
So exactly with the legislation and the facilities and the services that are being provided, then that should be able to form more part of the mainstream social experiences that people can actually engage in as well. So there's a whole level of acceptance that can come in increasingly more so once it's part of the social fabric, because social structure is what indeed dictates and determines social function. So if it's part of the social fabric and social structure, it can certainly promote the level of acceptance.
Yeah, and with the prevalence of drug and alcohol use and all of the type of behavior that result in some types of sometimes some sort of medical mental health problems. More and more, I think our society is appreciating because, for example, in Grenada, we now have a little more focus on rehabilitation and addiction counseling, and so that type of improvement over time, I can see that those are the things that make me optimistic about mental health in the Caribbean.
One of the topics that you touched in your initial presentation was that of the socio-economic determinants of health and the disparities that exist. And across the world, whatever population that you're engaging, there's always some type of at-risk group. Those individuals that are more prone, disproportionately affected by different disease conditions. And what I mean by disease conditions, it can be chronic infections, it can be acute infections, it could be debilitating disorders, it can be motor vehicle accidents, it can be domestic violence. So when we think about the within a society, there are always societies within a society. These groups somehow are not necessarily benefiting from the access and the availability and equity of different types of services as well. How can we, as a region, as a world, move more towards that type of social inclusion when a lot of conversations and efforts in the world in which we live in today is towards exclusion and division?
And that's where I focused on the conflict as the conflict theory as they look at the social structure. And saying, for example, that we can preach from now until forever, but that disparity and inequality will not change unless the social structure in the society changes. And what they're referring to when they speak of the social structure, that means the relationship, the ownership relationship to what in the theory they call it the means of production, but basically meaning who own the resources and assets in the society are the ones whose policies are more likely to be prevalent in that society. And so unless we do not address the ownership aspect of health, now, because it's an interesting phenomenon, because, for example, you look at the health structure in Cuba, for example, look at the health structure in Grenada. Grenada have a minimum type of social health, if I should say that, meaning that there are special categories in Grenada that people can basically access government-provided primary health care with little or no cost, right? And so what this is not that an idea that the government provide, but if you look at the structure of society, you would realize what is the mission, what is the overall objective of providing care, and so a lot have to do with who owns and who controls the machinery for providing the care, and what is the objective be. Is it aimed at profit, or is it aimed at providing care for the citizens? And if it's aimed at profit, you are likely to have a very high fee paying type of approach and understanding of while at the same time you may get the best of facilities and the best of equipment and the best technology, because the argument from that perspective is that that is the only way you're gonna get the best, maximize your care, right? But on the other hand, we know in societies as ours the extent of the number of our people who are living in poverty. and who cannot afford just basic care, just basic standard of living, right? In many of the countries, almost close to half of the population in reality. Many say it's in the 30s and 20s and 30 percentage of the population live in poverty. But we know in reality, in a lot of cases, it could be as high as 50% of our population living in poverty or under the poverty line. So it becomes extremely difficult to access healthcare, to access quality care, especially if it has to be paid for. So you'll hear the saying in countries like ours that it is easier to die and be buried than to seek medical care, because it's cheaper to buy a coffin or to cremate a body than to take renal problems.
Dialysis.
Dialysis is so expensive. There are a lot of people with a renal problem in Grenada. But how many can pay the $700 per session that is required for the treatment? So the decision is, there are more important things to the little money we have need to go somewhere else for the family, for the children, for something else, rather than my care. So we have those types of situations battling with. So it's an issue of poverty. So the inequality it will continue if nothing is done about the core, going beyond the surface now and looking at the core of what is the basis or the reason for that type of situation and who is responsible for addressing it. And that is where I think the medical profession can play a role in the particular, or the medical association in the particular countries or region can assist. So it is a combined effort of the association, the private sector, the government, because ultimately, if your population cannot work, is sick, they cannot work, and that's it. So unless that type of realization, that we get that realization that we all need to put our hand in this so that we can deal with the issue, then, it does not even make sense that you're making all this profit out of medical technology or medical care, and it will affect your quality of life, because where would you live? Who will care for you, etc., or your children and things like that. So that type of approach require a sort of combined effort. And it's happening all over the world. People feeling more disenfranchised, they're feeling less empowered, they're feeling that the inequality is growing and increasing. And so it's like a loud cry for help in many societies, including ours. That people settle. The expectation now has dropped to almost, there's no expectation. So as I get sick, let me plan my burial. Let's plan for my funeral from the time I'm diagnosed sick, rather than plan for care. And that approach seems to be overtaken, and that has much to do with the poverty situation in the society.
It's very, very, very disturbing to some extent, to be honest with you as well. But I can't help but think, let's take the position of the individual. So we've discussed the society, and no doubt the society is a reflection of individuals collectively. But what can an individual do to empower themselves in spite of the limitations of the society and the health system that they live in? And let me explain my context. Even in let's say impoverished societies, we have persons out there that are placing insurance on their vehicles, on their homes,
cell phone.
But what about insuring the body, your health, as an example? In many developing country contexts, the health services are more government funded or government supported as opposed to the private. And there is always this debate with regards to insurance-based health systems versus the social type of medical services. Now, there are advantages and disadvantages to both, no doubt.
Right.
But for those individuals who are in the lower socioeconomic standing, what will it take for an individual to assume that individual responsibility to protect themselves from the risk factors so that they have less worry or concern at the end point towards end of life care, the cost for the adverse consequences of health.
Right.
How about let's focus on the preventive, precautionary approach. Can that be a function of an individual? Can that be a function of society to take these individuals to move into that precautionary or preventive perspective?
Well, of course, I think a lot of it rests on the individual.
Yeah.
But again, when we look at these factors from a sociological perspective, we always go back historically and see what has happened. Now, many of our people were not exposed to a lot of stuff like education and the things that we know will help improve our quality of life, right? And so again, we go back to the issue of socialization and providing education at the earliest possible stage so that people learn to appreciate what is good. And they learn that, for example, preparing for old age was not a big issue in Grenada in the past. And people would not buy life insurance. They would not buy, they would not be concerned much about pension. Right? It's only in the 1980s we have developed this national insurance scheme that provides a very minimal pension for persons who would have worked in the system, both in the agriculture and the regular system over the years. But in the past, people weren't thinking about the future because there were some perceptions about the future. In other words, people made a lot of children because in their understanding of life, their children need to take care of them. And we're seeing how that is changing in society. You are responsible for your own care as an adult, but that was not the thinking.
Yeah.
And gradually we're seeing an erosion of that thinking, and people are now beginning to realize, I need to take care of myself in my old age. Pension is important, and this is the only way I can get pension because there is no free lunch, there is no handing out of subsidies or anything. So I have to take, and people are coming to that realization as children are no longer considered the investment or the property that they can depend on to take care of them in their old age. So a lot of what is happening, real life live situation and education, and we have to use every opportunity to educate people about and get them to realize that the world is changing, things has changed, the society is evolving in such a way that you are now responsible for your care in your old age. And so you have to begin to prepare for your retirement period and not think that your children has a responsibility to take care of you financially when you become an elderly.
I guess no matter how much you look at the issue, if you keep peeling out the different issues that are involved in context, there's always an underlying social and cultural.
It's always social.
No matter how you look at it.
Mm-hmm.
I try to get away from it. To be honest with you,
it's back to the
but it goes back.
Yeah,
it goes
yeah.
back to
Yeah.
the influences
Mm-hmm.
of the realities of people's lives. Certainly. Any other questions or any other comments from our audience?
Yes, there's a few more. I apologize. I just want to make sure. Have you answered this question from Desiree that it is? Would you say that it is not only the role of physicians to become open to culture, but also the role of society to become more open to physicians/science?
Yeah, so it goes both ways. Into the physicians themselves, I mean, we are advocating for total treatment for a patient. And total treatment is looking at the physical, the mental, and the social well-being. So healthcare workers need to really embrace and practice the understanding and the application of social determinants of health. But at the same time, society should also accept the functions, the roles, the capabilities of the medical fraternity as well. So there's an acceptance of both sides that needs to occur.
And when we speak of society here, could she explain what when she asked if society or just a physician should be open?
Yeah, let's see if I can unmute her microphone and see if she can ask directly. Desiree, I'm going to unmute you. Let's see if this works out.
Okay.
Hi.
Hi.
What I was referring to was like earlier we were saying it's our role as physicians to be open to the different cultures. But shouldn't it also be that the people of these cultures should also open their minds to us as physicians so that they could receive the better healthcare simply by accepting what we do?
I will caution you about the better healthcare. But of course, we have to appreciate your training and what you can bring to a client or a patient. I mean, no one else can do it better than you can. And the fact that someone will come to you for consultation means that they at least there's some they do have confidence in what you can do and what you can bring to the table. So we also have to understand there are some cultures. We have to, you as a professional, so I think the onus is on you to be more open. There are some people who are very shy about their situation. They come from cultures where they do not open up to people. And so we do not really want to blame them as a professional because we would understand that this person is relating their problem, but they would not look at me directly. And I am coming from a culture where you look someone in the eye and tell them exactly where the pain is. But they would not look at you, but they're going to be touching, they're actually having pain in the stomach, but they do not want to say it's a pain in the stomach. Or they may have some kind of prostate problem, but they do not want to say that that is where the problem, they're having a problem, that's where the symptoms, they may say, oh, it's a headache. It's a headache. That is coming out of a sort of a cultural training over the years. So sometimes we cannot really blame the client for the behavior. And so the onus is on you, the healthcare professional, to find a way to bring out what this and understand the behavior of the client, not really blame them and think that they're not open. But if you understand the cultural values that they're coming from, you are more likely to understand the behavior that they're expressing, the way they communicate their symptoms, the way they try to seek help. You know, they may pretend, I'm not really sick, doc, but I'm coming, I just want a checkup. But they're sick like hell, about to die. But they do not want, so are you as a professional learning to understand the context within which these people are coming with their thing is important. And how do you learn that? Is by you being the professional and open to all types of possibilities, because you're not only diagnosing a particular illness, but you're doing a sort of evaluation or assessment of this person's context in which they're coming from, if you understand the point. Is it, I know it sounds as a lot of work that you have to understand the cultural context and all of these social factors, but it certainly makes your diagnosis easier. It makes your work much easier, and I'm sure you will be guaranteed better outcomes as a result of taking an approach. It's much more time consuming, but it results in better outcome.
Okay, thank you very much. I get what you're saying.
All right.
Any other questions out there for us?
That's it.
Well, what we can do, in case we have any other final questions that come out of our attendees today, going forward, if I may put you on the spot, in a sense, if we were to projectively determine where will society change to next.
Okay.
Yeah, because ultimately we will determine,
of course. Yeah.
I mean, the future projection direction of society. From your finger on the pulse of themes and trends that you're observing in our current society, and also reflecting on the past, where do you see us going in the future? Maybe thinking about all the technologies and all of the different changing lifestyles that exist.
Well, definitely, I think you have answered your own question, because increasingly we've seen what technology is doing for this world. Many of the things that we even our communication style, how we convey different health problems right here, everything. So increasingly, it's a information revolution. Students don't even need school anymore, right? The classrooms anymore, because they're just, everything is at your fingertip. Everything you can know, you can find out information about any culture, any behavior. It's all out there, published, available. So it makes life so much easier to understand, but we have to find a way to ensuring that people utilize that information that is there. Because while there might be information overload, the beauty of the information age, this period that we're going through, because we have seen how society has evolved from hunters to gatherers, to slavery, feudalism, capitalism, what they call imperialism. And we have seen now the extent to which information and the access to information is changing every single practice. And of course, it's changing the medical industry. It's changing how you do your work, how you do your thing. You can stay at home now, and a patient can stay at home and you diagnose, you treat, and everything without even having to engage or encounter that patient. And that is a, the direction society is going. But at the same time, we have to think about how do we get society to pay attention to what is out there and available, to make use of the wealth of information that is out there, whether it is on lifestyle, on exercise, anything you want to do. I see people now, as soon as they have some symptoms, they jump on the medical internet sites, and immediately they're diagnosing themselves, they're treating themselves. And so in the profession, you have to think, how wise is that? There are some conditions that they may be able to learn some things, but we're having a much more informed clientele that now they know about certain things that maybe in the past only the doctors knew or had that authority. So what is that doing for your industry? People are questioning doctors more. They're challenging doctors more, because more and more people are realizing that you're not supposed to deal with only my medical issue, but there are a lot of things surrounding that you need to understand. So when children from the Caribbean come to you with worms, you know what we call worms, that their faces, they're passing parasitic infection, you will understand the environment in which they live that is a risk factor for worms, and do not see it as, you understand the context within which this, so as we think about how society is evolving, and we have to understand the power of this information that is, and access to information that is available, that is changing just about everything. The world has gotten so small now that, much of the methodology that we use in the past for research, for development of technology, all of these methodologies, we're seeing a radical change in all of this. So it's really what we consider in the social sciences a revolution away from the old way of thinking about everything to a new way of thinking. And the access people have all over the world to interact and communicate with each other, and the access that we have of medical information available at our fingertips, it's really changing the way people, the attitude towards physicians, the way they access physicians, the treatment regimen they get into. There are lots of alternatives, but the positive side of that is you learn a lot about lifestyle processes and activities that one can get involved in that can improve your health, because people are understanding more that it's not just the symptoms of that particular illness, but there are different, much of what is happening have a lifestyle aspect to it, that if you address the lifestyle aspect, you are likely to be treating yourself. So we have a lot of self-treatment within the industry now, and some of it could be very dangerous, but the positive part of it is that people are becoming proactive. They're empowering themselves. They're questioning the doctors. What you say now is not all gospel, right? So they're questioning, they're challenging you, and which is good for society and it's good for you, because the challenge helps you to continuously improve your craft. So That's the direction I see things going.
Interesting. I've learned a whole lot. Thank you for that. And I'm sure that we all have actually learned to appreciate and recognize the complexity of health and the significant role that society and culture has to play involving that. Just one more check, last check, to indicate if there are any remaining questions that anyone would like to have and addressed or answered. And if not, well, we have to thank you. Thank you for joining us.
Thank you for listening.
In our second installment of our course, One World, One Health, One Medicine, with particular focus and emphasis on the social and cultural determinants of health. We invite you to join us in March as we explore another aspect of health, in particular from a global context, as we celebrate our 40th anniversary at St. George's University. Let me remind you to ensure that you enroll in the course, because as part of enrolling in the course, online.sgu.edu/anniversary, that is the best way you can actually engage the post-seminar discussions. We have discussion questions, we have a very simple and short quiz for you, and over time, throughout this course, you can gain professional development credits, as well as part of engaging the full spectrum of what the course has to offer. So we look forward to you joining us on another installment of One World, One Health, One Medicine. I'd like to acknowledge the team that is behind this course. John Modica, who you have heard, moderating the session. John Soap, our instructional designer. And Donna Walker, who is our on-site support as well. I am Satish Bidesi, and until next time, enjoy the remainder of your February, and we'll see you guys in March. Goodbye for now.
Thank you. Goodbye.
Thank you. Pleasure.
Thanks very much to both of you.
Thank you. It is a very relevant topic.
Yeah.